All right? Okay. Now, the statistics about hypertension, right? 29% US adults greater than 18 years of age. Isn't that something? Greater than 18 years of age has hypertension. It increases with age, right? Remember we said from the time we are born, we start eating and we start, having effects on our vessels. And there's more black. That's why we're having the Black History Month event. And we want to do health teaching, health promotion for our college students. All right, that's why I'm inviting you guys. Non-Hispanic whites, right? Non-Hispanic whites, 28%, and Mexican Americans, 22%. So blacks have higher incidence. Okay. Now, safety. You want to make sure when you're going to use a stethoscope to check blood pressure that you clean it from patient to patient. So you know that. And make sure you have the appropriate size, right? For your patient, the appropriate size for their arm. Not too small, not too big. Because then it will give you inaccurate result. Clean your hands, right? Clean your hands well. Make sure the blood pressure machine is working, it's calibrated well. So you look at it that the calibration is on 0. Because sometimes it's off. That means you will get an abnormal result, right? So make sure the calibration is right. And if you have to repeat it, so then the patient has to sit for, you have to wait for a little bit in between, like 3 minutes before you repeat it on the same arm. Or maybe you can check on the other arm, right? You want them comfortable. You want that arm resting on something. It's better. Instead of just hanging like that, right? So you want to make sure that it is there, and they're sitting with their feet on the floor and not hanging. It's a little bit of, more stress on the body. Okay. So normal blood pressure, 120/80, right? Now, when somebody comes to the clinic to be assessed, and you check their blood pressure. So when we get 2 different readings, right? They get 1 month, 2 months later, right? Maybe 3 months later on follow-up. So if it was 140/90 here, and then they have, let's say, 138/86, they're going to add up the 2 and get some kind of average what it is. But they will more use the higher number to diagnose than to rely on the lower number. All right? So average of the 2 readings on different dates they look at, and then the highest reading is the category, how they classify the person, the group, that they will place the person on. Okay? So classification for hypertension. We have the pre-hypertensive stage when somebody is in pre-hypertension. So it's about the blood pressure, and we want the blood pressure, we said 120/80. So if we go up to 139, right? Because blood pressure, when it goes up to 140, is a problem. So anything that is 139 to less than 90, right? All right. So from here to to 89, right? So this is pre-hypertension. We're worried because now this is what it should be. That's what the normal should be, right? And now they're going way beyond that level, right? So pre-hypertension, we're looking at that person is in pre-hypertensive stage. We need to do teaching, they need to modify lifestyle, they need to be conscious of what's going on, what's causing it, right? So then when they are off beyond pre-hypertension, it's now stage 1 hypertension. So stage 1, now their blood pressure is now greater than 139, right? Yeah. So they're now 140. Right, to less than 160. Yes, 159. Right, and here we have 90 to 99. So less than 100. So that's stage 1, right? And then stage 2, they are greater than 160, right? Right? Greater than or equal to 160. Or when they're now up to 100, greater than or equal to 100, right? For diastolic, this is systolic, and this is diastolic, right? That's the classification, right? Something you have to know though, because you may get that in the exam, get numbers. How do you classify? It depends. Stage 1, stage 2, or pre-hypertension.
I'm going to ask you because before we started this, you said, but you classify them on the highest number, not the average of the two.
Right. Right. You choose the highest number, remember?
Regardless of, let's say, if
no, if you have to, right. For classification purpose, you're going to look at that, the highest one, and say, it's safer to use that and plan to, or tell them how serious it is, than to be in denial and use the smaller number, while occasionally or maybe more time they have higher numbers, right? So you use that to classify them, right? And being able to determine stage 1. So when we see patients, we want, if it's 140 over 90, right? See how we have that first number. I have 90 here, right? Okay, so so that's the beginning of stage 1. And then if it is greater than 160, that's a problem too. They are in stage 2. And over 100 diastolic, that's a problem too, right? So we need to teach them about follow-up care, right? When we look at that patient who has normal blood pressure, if their blood pressure is like this, they're fine. They can come in 2 years. Let's say if it's a younger person, right? Not somebody who's older, have other issues, then they can come earlier than 2 years, right? They can do their yearly annuals, okay? But for a normal BP, we don't worry about it. So 2 years is fine, unless other things occur in between. For the person in pre-hypertensive stage, right? Where we're saying this is pre-hypertension now, right? Over here, it's pre-hypertension. Okay, so we want to see that person come back, it's not up to 140. So they're in between. So they can come in 1 year, or the doctor may decide to come back in 6 months, right? But that's the average. Stage 1, they need to come back because it's high. We want to make sure we treat them. We're doing something, or they have modified whatever to be better, right? So 2 months. In stage 2, it's really high. Over 160, systolic, over 100, diastolic, come back in 1 month. That's the one the doctor will say, can you see me in 2 weeks? Whatever, in 1 month, they need to come back. All right? And they will even place them on medication and say, come back, let me see if it's working, if it's effective. Now, if the blood pressure is 180, greater than 180, and the systolic is greater than 110, that's a big problem. This person is at risk for, this is the acute problem that they must be treated. Immediate treatment is warranted at that level.
Greater than 110 or greater than 100?
110, look at it here, 110.
180 over 110.
Right? Well, remember it's like 100, between 100 to 110. Between 101 to 110. That's what it is, and greater than 160, it says greater than 160 up to 180. So that's a problem. Diastolic, we don't even want diastolic to be greater than 90. And then at 110, that's a big problem, all right? So blood pressure, we talked about it as the pressure exerted on the walls of the blood vessels, right? As the blood perfuses through the blood vessels. And the pressure, gives rise to the output, our cardiac output. Now, the things that affect the blood pressure, contribute to the pressure, is when we have problems within the cardiovascular system. We have problem with the blood vessels. We have resistance, peripheral vascular resistance, right? So, that person who has edema is not having good return, blood return. They're not having good perfusion. So there's more resistance, even atherosclerosis, hardening. Remember we're talking about the hardening and thickness of the, which is AR, atherosclerosis. Remember, there's more resistance because of less flexibility. So this person will have more peripheral vascular resistance, and that means it's more time and sluggish with the perfusion. They have more problem perfusing and blood return to the heart. Taking all those deoxygenated blood, getting it back to the heart to be oxygenated, right? Or to the lungs. So they have more problems. Vessel stretch. Remember I said flexibility, right, of the vessels or elasticity is decreased. So there's more problem with that stretching. It's not working. Viscosity of the blood, right? So if we have narrowed blood vessel, edema, and we have stasis, we have more volume, it will make the blood more viscous, right? So it takes more time, more sluggish. It's more time, a lot more pressure to push through a highly viscous substance, blood. So these things contribute to the blood pressure, our output, the vascular resistance, right? Vessel stretch, viscosity, and the volume. If we don't have enough volume, somebody who's anemic, they don't have enough volume. When we are dehydrated, we don't have enough volume. So we're expecting good perfusion. We can't have that if we don't have the volume. So those things also affect, okay, now the heart has to work harder, now the muscles, the marrow will have to produce more blood, right? So if we don't have enough volume, that also affects the pressure.
If the blood pressure problems, can you start having all these problems when you are on stage 1?
Yes. Right. The person in stage 1, they're already hypertensive. Right. Even in pre-hypertension, they will be feeling those things as well. Right? Because they are in pre-hypertension because of maybe they have, coronary artery problems, disease. Because of arteriosclerosis, right? Or diabetes, or some of these problems contributing to it, causing peripheral vascular resistance. Remember the diabetic patient has peripheral arterial disease?
Yeah.
So they have resistance.
Why is there more blood volume? Wouldn't there be less blood volume?
Where's more blood volume?
In that slide, it says blood viscosity and blood volume.
Right, when we have less volume, it doesn't say high blood volume, it doesn't. When we have less volume, right, that's the problem. We don't have enough. It will even lead to low cardiac output, right? When we have low volume, right? And even if it's high volume, where we have congestion and poor return, that's another problem too, because they're not able to, perfuse well, right? So primary hypertension. Some people develop hypertension, we don't know the cause. A lot of times we don't know the cause. Primary, right? There's nothing else contributing to it. All of a sudden, that person who was fine, and then maybe this year they went to the doctor, all of a sudden the doctor said, oh, I think your blood pressure is being up, right? Last year it was this. The last time you came, it was better. Now it's a little higher, right? So we don't know the cause. But we know also there are other things that contribute to it, all these other issues we talked about earlier, right? Secondary hypertension. Remember, we had secondary diabetes because of other issues. Remember secondary diabetes? Somebody who has to be on prednisone because they have COPD. Somebody who has to be on dilantin because they have seizures. Secondary, due to other causes. Now, the same thing goes for hypertension. Somebody who has secondary hypertension because they have kidney failure. Because they have diabetes, they have kidney failure. Remember we talked about the aldosterone and the AMP that controls the sodium, potassium levels. And of course, it goes through the kidney, right? Kidney filtering, right? And, through perfusion also. So maybe because somebody has impaired kidney function, now they become hypertensive. There are other systems that control the pressure. All right, so secondary hypertension, maybe abnormality within the endocrine system, or the negative feedback mechanism. Remember, they balance the homeostasis. So those things, all right, the production of aldosterone goes with the endocrine system because it has to be through the hypothalamus and whatever, different things that stimulate release, right? So if we have problems, it has to go through a sequence. Something has to stimulate the organ to produce it. And if the thing that stimulates the organ is not working, then the organ will not. Remember, we talked about the pancreas and how it needs to be stimulated to produce insulin. And if there's tissue insensitivity, right, that goes on also with this. If secondary, because of other problems, right, and the person is in secondary hypertension. Isolated systolic hypertension, where the systolic stays elevated for some reason, isolated, no known cause, right? Just you check their blood pressure, their systolic seems to be, elevated, sustained elevation of the systolic. Okay, so that's just different things. Somebody who is hypertensive can be it's a primary hypertension, or this person has hypertension because it's a secondary cause, or just isolated elevated systolic. All right. Signs and symptoms. We say it's a silent killer because sometimes people have no symptoms, and we say women even are at greater risk because they don't have the typical symptoms, and then they take longer to get care. So rare, sometimes people have headache because it's too much pressure built up, right? And even as the blood perfuses to the brain, they also feel the pressure. So bloody nose, okay, these are some of symptoms people may complain about, but it's not always typical. Some people don't get these signs, and then they'll get a stroke, and they say, "Wow, there was no warning." That's why it's called a silent killer. Sometimes they have no warning. Anxiety can cause anxiety when you're really uncomfortable, because the heart is really working overtime, right? Dyspnea, because it's not perfusing well, poor cardiac output, low cardiac output, then they will have difficulty, shortness of breath, and all those things, right? Target organ, the thing about hypertension, when we have so much pressure built up, and the body has to deal with that, because it's not just having the pressure built up, right, the high blood pressure, it's the compensation that follows it. It's the way the heart has to even now work harder to meet up with that need, right, with all the problems, whatever may be causing that elevated blood pressure. Then it starts causing problems in some major vessels, major organs of the body. So we think about target organ disease because of sustained high blood pressure. So everything now will have to compensate. All the organs will have to compensate, right? Because the same blood that has high pressure within it is circulating through the body, going through the brain, going through the liver, the kidney, right? So those are the target organs, the heart, the vessels that supply the brain, the eyes, right? So target organs are destroyed or damaged because of sustained high blood pressure. All right, so these people who have high blood pressure often have problems with damage to the heart, right? Because we're going to deal with congestive heart failure and what happens, some hypertrophy, all the thickening and hardening that occurs. Kidney damage, brain, right? They can have stroke. They can have a busting of the blood vessels because of the brain is contained only within this hardened place. There's not enough space for it to expand. So when we have so much pressure built up, it causes headache and it can burst. That's why people get stroke, right? Eyes, we can also burst the small vessels that supply the eye. We talked about the diabetic patient having retinopathy. The hypertensive patient can also have, bloodshot eyes from so much pressure built up. So history, we want to know their history. What are their signs and symptoms? Any kidney or heart involvement, right? Medications that they are on. Are they taking medications? Are they compliant with medications? What are their blood pressure readings? Maybe they're keeping their blood pressure, they're keeping a record. So the hypertensive patient also needs to keep a record, a diary, just like the diabetic patient. Because you take it, you go to the doctor, and the doctor will kind of know how the treatment or the plan is working, is it effective or not, right? Diagnostics, same things, like we talked about in the other chapter 21, is all the diagnostics that's done. You need to do, electrocardiogram, right? Blood glucose test, right? Because patients that are diabetics have problem with their blood vessels, and they tend to develop hypertension, because they have peripheral vascular problems. Hematocrit level, right? Potassium level. Potassium helps with cardiac functioning. When it is abnormal, they can have symptoms. Calcium level, right? Because they all help with the muscle function and the muscle of the heart that pumps, Lipoprotein level, cholesterol level, triglycerides, all those cardiovascular labs we talked about in the first chapter, all right? So these things are hypertension, risk factors. So now, risk factors for hypertension. For patients that have high blood pressure, have certain factors that predispose them to high blood pressure, right? But we have to look at the factors as factors that can be modified or factors that you can't have no control over. That means they cannot be modified. So you got to know that also from now till the time you graduate. Those factors that are modifiable and the factors that are unmodifiable. All right? Now, non-modifiable risk factors, the ones we have no control over. If we become hypertensive, we really have no control over the fact that if I am 80 years old, I have no control over that. Right? We know that cardiovascular changes that occur can predispose me to hypertension because of all these atherosclerosis, right? Ethnicity, I have no control over that, right? So it's there, and we just have to deal with it. If I am diabetic, right? I'm diabetic, and we have family history of somebody in the family who has diabetes. I have no control over it, right? I have no control over the fact that I'm diabetic. Now it changes. When we go to modifiable risk factors, you see, there is diabetes there too. I don't know why this one doesn't have any safetiness. Okay, diabetes, tends to be there too, because if you can now control your diabetes, then the effect of diabetes can now be modified.
So
It delays the onset, right, of problems if you can put it under control. So first, diabetes is under non-modifiable
And that would mean
because
type 1.
and type 1 mostly, right, because genetically you are predisposed. So modifiable risk factors. Wait, if I'm obese, I could do something about it if I have the will, right? So I can modify it. The diet that I eat, whatever I put in my mouth, I can modify it. So I can decide I'm never going to eat anything that has salt anymore, right? I can modify it if I have the will, right? Low diet. So they have this dash, on low sodium. Limit sodium, limit caffeine. Caffeine can increase your heart rate. Okay, alcohol use, right? People who are dependent on alcohol. Exercise, right? Exercise, if it is what's causing you so much stress, right? So you make sure you're doing what with the direction of a doctor, that you're not overexerting yourself, and you're doing what your body can deal with. Smoking, right? Smoking, cessation, stress management. If you have the kind of job that puts you at so much stress level, if your lifestyle is, you have to worry so much about everybody and everything, stress management, learn to do that. Adequate sleep. Sometimes we don't have enough rest, we don't sleep enough, right? We go from one job to the other, then we come to school, we stay in the class, we fall asleep. Like that happens a lot. Adequate rest. We can do something about it. Because if we're not resting, we're going to have problems.
What is DASH purpose? Does DASH, that's what you
No, dash, this is your book.
Diet.
Uh-huh. Epileptic? Acronym. It's an acronym. It is an acronym. Yes. It's dietary approaches. Dash, you see that? It's dietary approaches to stop hypertension. Different things, so, which focuses on limiting sodium, limiting canned food, yes.
Okay, for one, the quantifiable risk factor is diabetes. If you get it under control, not under control, it's non-modifiable.
No, not modified. It's not modifiable when you are genetically predisposed to, and you have no control over your genetics.
So then it would be diabetes type 1.
Yes.
And then the second one would be type 2, right?
Yes.
Okay.
Right? Yes. Yes, type 2 modifiable. You can do something about it. Yes. Right? So treatment. When you have no risk or low risk, right? So you just, be conscious of your lifestyle and modify lifestyle to be appropriate, right? So you will not suffer the effects of hypertension, right? When you have no risk or low risk, you modify lifestyle. When your blood pressure is in greater than 140, right? Which is what? Stage 1? Over 6 months, you need to really do something. It's, we had like one year, is that it? On that 1 year on the slide, right? Pre-hypertension is 2 years.
Normal is 2 years.
Normal is 2 years. And
Hypertension is 1 year.
stage 2. Stage 1, then stage 2.
2 months.
Stage 2 is 1 month.
All right, so if we are maintaining 140 to 190, over 190, so within the next 6 months, we really need to do something about it, right? So treatment, one month to 1 year, you want to do something about it. Goal of treatment, you want it to be less than that. You want to be in pre-hypertension, or better control if you can get to the normal, right? So the goal is to keep it below 140 over 90, right? Below 140 systolic, below 90 diastolic. And if the person has diabetes or kidney failure, they already have underlying problem. So if we can keep it at 130 over 80, it's okay. Understand, that's what it's saying, less than 130 over 80. If they already have problems, we know that because of the kidney problem, which controls blood pressure, we may not get it to be normal level. All right, so lifestyle changes and medications. We may need to use both changing, modifying our lifestyle and being on medication. If we have it, greater than 140, then they may need to be on medication. Antihypertensive meds, which we have so many antihypertensive meds. Initial therapy for a hypertensive patient, when they're going from pre-hypertension to stage 1, and they want to start them on medication. The initial therapy, what did I say? Thiazide diuretic. They start them with diuretic. They don't start them with Norvasc, right? They don't start them with antihypertensive med. They want to start first with thiazide diuretic. Okay. To start treatment, medication. Anytime they want to resume in stage 1 or even if they're coming out stage 2, a hypertensive patient, for them to start giving them meds, they want to start first by giving them diuretics. And they try that, and then they have to come back for follow-up. And they want to see, did that work? And if it didn't work, they will need to add a hypertensive med, antihypertensive medication. Right? So they can have a combination of meds. So you see a lot of hypertensive patients have not only hypertensive meds, they also have the diuretics, water pills. Okay. So diuretics, they have the different groups of hypertensive meds: alpha blockers, beta blockers, calcium channel blockers. Remember I said it's better that you learn them by classes first and know examples of the classes. because when you learn them by classes, it will be kind of a group of meds under the class. And you kind of know what the class, what they do, right? What they represent, what's the action of the class, right? So it helps you to know, okay, beta blockers, these are the things. Do I need to check, know what blood pressure is before I give you? Do I need to know what their cause is before I give them medication, right? So, and what your responsibilities are before you give the medication. Angiotensin converting enzyme inhibitors, ACE inhibitors, right? Those are the prils that we were talking about. Those meds, their name end in prils, right? The prils. Central agents, there are meds that are centrally acting medications. So central nervous system action. So they are inside centrally. So they are more effective. So these drop your blood pressure so quick because they are centrally acting. Like what's the example? Clonidine. Clonidine is an example. Clonidine. They have peripherally acting agents also. Then we have vasodilators. Then aspirin. So cardiovascular patients have to be on aspirin, one aspirin a day, 81 milligram, baby aspirin, most of the time. It's only like under special circumstance that they order the 325 milligram aspirin. But most people, they place them on 81 milligram baby aspirin every day, right? Complications of hypertension. Remember, so much pressure built up over time, they can develop atherosclerosis, coronary artery disease, myocardial infarction, left ventricular hypertrophy, because now the muscle is beating so fast, so heavy, have to work overtime to compensate for that high pressure. Stroke, they can get stroke, right? That's complication. If we're not treating well, if we have the 180 patient, if that lady, right, we said women have atypical symptoms. So they have a headache all day long, their pressure is high, but they have to go to work before they come back, right? They can get stroke. Kidney damage, target organ damage, right? The eye damage, the brain, right? So these are complications associated with hypertension.
Professor, what's the difference between a stroke and an aneurysm?
Okay.
Like, I know it's almost the same bodies, but what's the difference?
Okay. Well, an aneurysm, it affects the blood vessel. You have a blood vessel that, because of so much built up pressure over time, the walls of the blood vessels now become very thin and weak. And so the more the pressure is built up, it can easily burst. It bursts. Same thing goes with a stroke. Remember, stroke has different things that can cause stroke. Can be a bleed from the bursting in the brain, or it's a blood clot that clogs the blood vessel and does not allow blood to flow, embolism. So those two, that's why they determine, is it a bleeding stroke, hemorrhagic stroke, or is it because of a clot that clogs it? So it's not bleeding, because when it bleeds, it opens up and everywhere it's filled up. If it's in the brain, it causes so much pressure because the whole place is filled up, right? So hypertensive emergency, right? We said if it's greater than 180, we must treat immediate treatment. It's an emergency because that person can have symptoms. They can have tingling sensations. They can have weakness, numbness, right? Because it's so much pressure. And so it's an emergency. We need to treat. We need to treat and bring it down. Diastolic of 120, that's really high, right? There's risk. The worst thing is that the organs will be damaging with that high pressure. Target organ damage, that's the risk. Progression to organ damage or organ dysfunction. So we must treat right away, okay? Immediate or gradual reduction of BP to protect target organs. So we need to, reduce our blood pressure, give you medication. So depending on some of these meds, we may need to give those centrally acting meds to drop it quick, all right? Treatment, we can give nitroprusside IV, or some of the centrally acting meds That's Nomodine. Nomodine is another medication. Nomodine. It's also called anyway. Nomodine, clonidine. Those are some of the centrally acting meds, blood pressure meds that will drop your blood pressure real quick. So most of them, for them to give it, they give a parameter. So if the blood pressure, let's say systolic is less than 140, they may say no, don't give it because it's going to drop fast. Right? They give parameters for most of the centrally acting meds. All right? Urgencies. Hypertensive urgency. When we have severe elevation without target organ damage, and we have dysfunction, progression to organ damage, severe headaches, nosebleeds, right? Because there's so much pressure, even the tiny vessels that supply the nose, the person can bleed from it. Shortness of breath, severe anxiety, and oral. They can give oral medication after you have addressed it and brought down the blood pressure. Nursing process, ineffective therapeutic regimen management, right? Ineffective deficient knowledge, non-compliance, right? Decreased cardiac output, impaired oxygenation. There's so much, right? Patient education, lifelong blood pressure control, right? They need to, especially when you know you are at risk, when you know you have those non-modifiable factors that predispose you to. You need to keep it under control, because if you don't, you're going to be at risk for problems. Self-care measures, and they have to, adhere to whatever is prescribed. If it is lifestyle management plus medications, they need to do that. Exercise and different things, right? So that's it. Please, last one. Last one. I know you want to leave. You already did it this morning, so you will know it better now. Please put. Sorry. That's the last one. I'm not going to tell you guys again. This is the last day. Don't you like to take exams before class?
Yes.
It's good, right?
Yes.
It's really good. Yeah.
That's right, we all want high blood pressure.
Yes. Yeah, next
First, but I'm glad that you
yeah, then we'll have a long time,
Now I know why, now I know why they're repeating it.
The concept map, and then you guys say no.
No, but other people are saying, but I'm just. Yeah, but this is my last class.
To pick up, right? Okay.
You gotta go and keep living on, right? Or we don't, you gotta find something. That's true, it's so true.
It's 5
Yep. And it is, I'm just like, if, I'll do it, I ain't even making no plan, I ain't taking that Just keep saying it's easier.
Oh, I gotta do mine. Here you go.
Yeah, she's only 10 weeks. Sometimes they have 6 to 10.
And then sometimes.
Oh,
The summer class is 6 to 10? The last one?
For those of you that came in late, they have a tutor in the in the library. This is his name on Mondays from 12 to 5. All right, you can go for help. Don't wait until the last minute. Put in time into the study.